Hello, I'm Jennifer Saucier, Manager of Genetic Counseling Services at Natera, and I will be moderating today's presentation. We thank you for joining today's webinar entitled Silent but Dangerous, the Value of Enhanced Spinal Muscular Atrophy Screening. Throughout the webinar, please feel free to submit questions by using the QA feature at the bottom of your screen. We will answer all questions at the end of the presentation. Now I'm honored to introduce our two speakers. Speaking first will be Dr. Ruth Kornreich. Dr. Kornreich is the lab director at Mount Sinai School of Medicine, an associate professor of genetics and genomic sciences, and an associate professor of obstetrics, gynecology, and reproductive science. Dr. Kornreich received her PhD from City College of New York. Our second speaker, Dr. Lisa Edelman, is the director of the Mount Sinai Genetic Testing Laboratory and associate professor in the Department of Genetics and Genomic Sciences. Dr. Edelman received her PhD in molecular genetics from the Albert Einstein College of Medicine and is certified in clinical molecular genetics and clinical cytogenetics by the American Board of Medical Genetics and Genomics. Now I'm happy to turn things over to Dr. Kornreich.
Thank you, Jennifer, for the introduction, and thank you for joining us today to learn more about the value of enhanced spinal muscular atrophy screening. The presentation will be divided into three major sections. First being a clinical and molecular genetic overview. The second part will focus on carrier screening and considerations. Lastly, efforts towards the detection of silent carriers and improvement of residual risk estimates will be discussed. Spinal muscular atrophy, which we'll refer to as SMA throughout this webinar, is a common autosomal recessive disorder characterized by degeneration of the anterior motor neurons of the spinal cord, leading to atrophy of the proximal muscles of the limbs and trunk. The disease was first described by Warding and Hoffman in the 1890s. SMA is the second most common fatal disorder after cystic fibrosis, with a carrier frequency of 1 in 40 to 1 in 60, with an incidence of approximately 1 in 10,000 births. The genetic defect was localized to chromosome 5q13, and survival motor neuron gene, SMN, was identified as the disease-causing gene in 1995. There are two almost identical SMN genes on 5q13. The telomeric SMN1 gene is the SMA-determining gene, and the centromeric SMN2 gene may alter severity of disease. The coding sequences differ by a single nucleotide, which does not alter the amino acid sequence, but results in alternative splicing of exon 7. Reduced amounts of full-length transcripts are produced by SMN2. mRNA lacking exon 7 gives rise to truncated and unstable proteins. The vast majority of patients lack both copies of their SMN1 genes, which results in insufficient levels of SMN protein in motor neurons. SMA is classified into 4 grades of severity by age of onset and motor function achieved. There is physical disability with all types. The weakness is usually symmetrical, more proximal than distal. The legs are more affected than the arms, and the diaphragm and facial muscles are typically not affected. Despite this, respiratory problems are an important complication of SMA. Type 1 is the most severe and common type and accounts for about 50% of SMA patients. Infants with type 1 SMA have onset by 3 months of age, never acquire the ability to sit without support, and generally do not survive beyond the first 2 years of life. Patients have profound hypotonia, lack motor development, symmetrical paralysis, and a characteristic respiratory pattern. Patients with the most severe form have prenatal onset of disease and present at birth with joint contractures and severe weakness. Type 2 SMA is characterized by onset of disease between 6 and 12 months of age. Patients can sit unsupported, and some are able to stand but cannot walk independently. They typically survive beyond 4 years of age. There is a wide range of severity in this group, ranging from significant weakness with respiratory insufficiency to children who can sit and crawl. Prognosis is largely dependent on respiratory ability. Type 3 disease has onset after 2 years of age into adulthood. Most patients can walk independently but may need wheelchair assistance in childhood, whereas others continue to walk into adulthood. Type 4 patients present with symptoms in their 20s and 30s and have a milder course. It should be recognized that all SMA types share the same etiology and demonstrate a continuous spectrum of severity with onset in utero to adulthood. The major pathological features of SMA are loss of motor neurons of the ventral spinal cord and lower brainstem and subsequent muscle atrophy. Neurodegeneration of SMA is characterized by the loss of large motor neurons, shown by the arrow in section A of the slide. The bottom of the slide shows the atrophic muscle fibers interspersed with hypertrophic fibers. The groups of fibers vary in size and are arranged in large groups of 30 to 200 fibers. Currently, there are no effective disease-modifying treatments for SMA. Treatment involves a multidisciplinary supportive approach. However, recent insights into the pathophysiology of SMA have revealed potential novel treatment strategies with many clinical trials in process. Currently, there are three major efforts. The first involves strategies to increase full-length SMN protein by using pharmacological compounds or through splicing correction of SMN2 mRNA by antisense oligonucleotides. The second strategy involves ways to introduce exogenous SMN1 gene copies using gene therapy or stem cell therapy. The third group involves strategies to protect motor neurons, such as gabapentin, to reduce glutamate-mediated toxicity. This slide shows some of the most promising emerging molecular therapeutic approaches being investigated or in clinical trials. It is likely that clinical care for SMA will change in the not-too-distant future. The SMA region is effectively contained within a segmental duplication on 5q13 with SMN in one copy and SMN2 in the other. This locus contains multiple repetitive and inverted sequences with two highly homologous copies of SMN. Both genes differ by only 5 nucleotides. Only one of the 5 differences between SMN1 and SMN2 is in a coding region, that being position 6 of exon 7. Although this mutation is translationally silent, the C to T transition alters the splicing pattern in SMN exon 7. SMN1 exclusively produces full-length functional transcripts, while 90% of SMN2's transcripts lack exon 7. The SMN protein produced without exon 7 is unstable and is subsequently degraded. SMN exon 7 has weak 3' and 5' splice sites and needs additional cis and trans-acting splicing elements to be correctly spliced. The cis elements include exonic and intronic splicing enhancers and silencers. These cis elements are recognized by trans-acting proteins. There is an exonic splicing enhancer in exon 7 which binds a positive splicing protein to which a complex of proteins binds to facilitate the inclusion of exon 7 in transcripts. The cytosine at position 6 of exon 7 is essential for the inclusion of the exon into mRNA, while the thymine most often causes exon skipping. The C to T nucleotide change disrupts an exonic splicing enhancer sequence and creates a splicing silencer element that binds a repressor protein. As said before, approximately 90% of the SMN protein produced by SMN1 transcripts is full-length, while only 10% of the transcripts from SMN2 are full-length. Only the full-length transcripts produce stable functional proteins. The SMN protein has numerous diverse functions in cells and is part of a large macromolecular complex involved with splicing of pre-mRNA into mRNA. It is particularly important for splicing a subset of lower motor neuron-specific genes. The vast majority of SMA patients are homozygous for loss of both copies of SMN1. Patients with type 1 SMA generally have 1 or 2 SMN2 copies, which produce about 20% of SMN protein. Patients with type 2 SMA generally have 3 copies of SMN2, with one of the copies arising from a gene conversion of SMN1 to SMN2. Patients with type 3 SMA typically have 4 copies of SMN2, which produce about 40% of SMN protein. SMN2 is a modifier for SMA phenotype with an inverse relationship between SMN2 copy number and disease severity. High copy number of SMN2 ameliorates the clinical severity in some patients. Complete loss of SMN2 has not been observed in any SMA patients with homozygous SMN1 deletions, suggesting that complete loss may lead to embryonic lethality. However, correlation between disease severity and SMN2 copy number is not absolute, as other factors may also modify clinical phenotype. Therefore, SMN2 copy number should not be used to predict outcome in a prenatal setting. I will now turn it over to Lisa Edelman, who will introduce SMA carrier screening and enhanced testing.
Testing for SMA in affected patients is relatively straightforward and can be done by assessing the absence of exon 7 in the SMN1 gene. The single-base change in exon 7, which was described in the previous slides, can be exploited to preferentially amplify SMN1 and avoid amplification of SMN2. Carrier screening is not as straightforward, as it assesses loss of single copy and must be performed by dosage analysis methods, such as multiplex ligation-dependent probe amplification, quantitative PCR, TACMAN technology, or some other derivative method. SMN1 sequence analysis may be useful in 1 to 2% of patients due to compound heterozygosity for an intragenic mutation with loss of SMN copy number on the other allele. In addition, linkage analysis has been used prenatally when affected haplotypes are known. This method may be particularly useful in pre-implantation genetic diagnosis. And finally, SMN2 copy number can also be assessed by dosage-sensitive technologies for disease prognosis in affected patients, as was previously mentioned. Carrier screening for SMA became widely available in 2008 as dosage-sensitive methods became more robust and reliable for clinical testing. The American College of Medical Genetics issued practice guidelines in 2008 recommending carrier screening for SMA for all couples based on several criteria, including panethnicity of the disease, the greater than 90% carrier detection rate, and the severity of the disease. A year later, the American Congress of Obstetricians and Gynecologists released a statement against SMA carrier screening in the general population and recommended pilot studies, assessment of cost effectiveness, development of educational materials, and standardization of laboratory results. ACMG reaffirmed their position in 2013, and despite these opposing views, SMA is currently present on most clinically available carrier screening panels. I will go through one of the quantitative technologies, multiplex ligation-dependent probe amplification, or MLPA, in detail, mostly to highlight the complexity of the assay and the need for robustness and reliability when performing dosage assays in a high-volume clinical laboratory setting. MLPA is a variation of the multiplex polymerase chain reaction that permits multiple targets to be amplified with only a single primer pair. Each target region is assayed with 2 oligonucleotide probes which recognize adjacent target sites on the DNA. One probe contains the sequence recognized by the former primer, and the other is the sequence recognized by the reverse primer. Only when both oligonucleotides hybridize to their respective targets can they be ligated into a complete probe. The advantage of splitting the probe into 2 parts is that only the ligated oligonucleotides, but not the unbound probe oligonucleotides, are amplified. The forward PCR primer is fluorescently labeled. Each complete probe within the assay has a unique length, so that its resulting amplicons can be separated and identified by capillary electrophoresis. A set of wild-type controls is run with every assay, and a dosage quotient for each probe is determined by the ratio of the wild-type to the patient fluorescent signal intensity. There is commercially available MLPA kit that interrogates both the SMN1 and SMN2 genes and compares the individual dosage of each gene to the combined dosage of both genes. The combined dosage should be equal to the sum of the individual gene dosage, acting as an internal control for the assay. MLPA results can be displayed in tabular form with dosage ratios converted to clinical interpretation. For example, a ratio of 0 indicates 0 copies or affected status, whereas a ratio of 1 indicates 2 copies and is wild type, and a ratio of 0.5 indicates 1 copy or a carrier. Despite the utility of quantitative methods in determining carrier status, there are a number of limitations. Carrier testing using MLPA or quantitative methods such as qPCR provides only the copy number information. It will not detect carriers with pathogenic intragenic variants. MLPA also cannot distinguish the 2+0 genotype or silent carrier, with both copies of SMN1 in cis on one chromosome 5 and 0 copies of SMN1 on the other chromosome, from the wild type or trans configuration with 1 copy on each chromosome 5. In addition, de novo mutations occur in 2% of individuals with SMA. Of note, the region has a higher than average recombination rate, most likely associated with the segmental duplications that comprise it. Therefore, when only one member of a couple is a known carrier with 1 copy of SMN1, the residual risk of having an affected child is not 0 and varies based on ethnicity. The SMA locus is highly polymorphic with respect to copy number. The wild-type scenario is 1 copy of SMN1 on each chromosome. A carrier has a deletion or loss of copy on SMN1 on 1 chromosome. There are also duplications of SMN1, which are fairly common, where an individual has 3 or more copies of SMN1, with 2 copies on 1 chromosome and 1 or 2 copies on the other. And a silent carrier is someone with a duplication or 2 copies of SMN1 on 1 chromosome and no copies on the other. Copy number results of a silent carrier are not distinguishable from the wild-type situation, since both have 2 copies of SMN1. The carrier frequency of SMA varies by ethnicity, ranging from 1 in 35 in Caucasians to 1 in 117 in Hispanics. The detection rate also varies, with the highest detection, 95%, in Caucasians, and the lowest detection, 71%, in African Americans. The number of silent carriers in a population is directly proportional to the number of SMN1 deletion carriers and the number of individuals that have SMN1 duplications. It should be noted that in Ashkenazi Jewish individuals, about 16% of the population has 3 copies of SMN1, which is twice the frequency in the Caucasian population. And interestingly, about half of all African Americans have 3 or more copies of SMN1. The large number of duplication alleles and thus silent carriers in the African American population is the basis for the lower detection rate by copy number analysis. To attempt to improve detection rates for SMA by identifying silent carriers, we began with the Ashkenazi Jewish population because there are well-documented founder effects in this group. Although pathogenic variants of SMN1 are primarily deletions and gene conversion events, the same principles regarding other founder mutations should apply. mainly that founder alleles should be present with extended regions of linkage disequilibrium, and that population bottlenecks or selection should have fixed the founder mutations in the population at a certain frequency. Taking this into account, we hypothesized that founder alleles that are either deletions or duplications of SMN1 would be useful in identifying silent carriers. Toward the goal of identifying deletions or duplications that are Ashkenazi Jewish founder alleles, microsatellite analysis was performed with markers that flank the SMN1 and SMN2 genes in order to determine whether haplotypes specific to deletions or duplications of SMN1 could be identified. A set of 6 markers spanning approximately 4 megabases on chromosome 5q13 were used to interrogate 78 wild-type controls, 20 deletions, and 51 duplications. The results are shown on the next slide. Statistical analysis was applied to the microsatellite marker data, and a single founder duplication haplotype was discovered that was absent in controls and was present in half of the individuals with SMN1 duplications in the Ashkenazi Jewish population. In particular, 2 markers, MS1 and D5S610, which flanked SMN1 proximally and distally respectively, were identified. Allele number 6 of marker MS1 and allele number 10 of D5S10 comprised the conserved haplotype. Individuals carrying duplications with the 610 haplotype were next sequenced to determine whether a specific sequence variant could be used to identify the duplication allele rather than microsatellite analysis, which is cumbersome for routine clinical use. Initially, Sanger sequencing of intron 6 through exon 8 was performed, and a novel single nucleotide variant in intron 7 was identified that was specific to the duplication alleles in the Ashkenazi Jewish population and absent in controls. The single nucleotide variant is delineated with its genomic designation G27134T to G. It creates a restriction site for HPY-CH42. Additionally, next-generation sequencing was performed to assess the entire SMN1 genomic region in 610 duplication carriers, and a duplication-specific haplotype was identified across the SMN1 gene, with novel single nucleotide variants identified in introns 1, 2A, 6, and 7, and a dinucleotide variant in exon 8. The G27134T to G variant was always present with the other variants as a tightly linked haplotype. Therefore, the variant could be used alone to infer the conserved haplotype of the 610 allele. We next determined whether the G27134T to G variant was also present on duplications from individuals of other ethnicities. Therefore, we tested a few hundred individuals of Asian, African American, Hispanic, and Caucasian ancestry. We found that the variant was present on duplications in all populations tested. In Asians, like the Ashkenazi Jewish population, it is specific to duplication alleles and not present in wild-type individuals with 2 copies of SMN1. In African Americans, Hispanics, and Caucasians, although present on duplication alleles, the variant is also found in individuals with 2 copies, but at a much lower frequency than on duplications. The table shows the results of the screening. Numbers highlighted in yellow are the number of single copy alleles that were positive for the variant. The full Ashkenazi Jewish single nucleotide variant haplotype identified in SMN1 was also present in all ethnicities tested. However, the extended microsatellite haplotype that covered the region of 4 megabases flanking the SMN1 gene was only present in the Ashkenazi population. These results suggested that the SMN1, this particular SMN1 duplication allele likely represents an ancient allele. Based on the results of the screening shown on the previous slide, we were able to demonstrate that addition of the variant to copy number screening assays could improve detection rates in the Ashkenazi Jewish population from 90 to 94%, as well as modestly in the Asian population from 92.6 to 93.3%. Importantly, the residual risk estimates could be modified using Bayesian analysis to determine risk after a negative copy number result of 2 copies of SMN1. Being positive or negative for the single nucleotide polymorphism significantly impacts residual risk estimates in all populations tested. In particular, in African Americans, the residual risk, if negative for the variant, goes from 1 in 121 down to 1 in 396, and if positive in the variant, for the variant, from 1 in 121 up to 1 in 34. This table shows the results of combined copy number assay and genotyping of the G2713-4 T to G variant, referred to as enhanced SMA testing, in over 10,000 individuals screened of all ethnicities. About 2% of individuals with 2 copies of SMN1 test positive for the variant, and about half of the individuals with SMN duplications with 3 or more copies test positive for the variant. When individuals with 2 copies of SMN1 test positive for the variant, it is recommended to test the partner and provide residual risk estimates to the couple. Breaking out specific numbers for the Ashkenazi Jewish population, we found 5 silent carriers in 670 screened for a frequency of 1 in 334, and roughly half of the duplication carriers with 3 copies or more are positive for the variant, confirming previous results. Our experience with SMA testing, enhanced testing in the prenatal setting, has included testing a silent carrier couple with an affected child. Both members of the couple were African American. One member of the couple tested positive for the G2713-4 T to G variant. Consider the risk to an African American couple in the following scenarios. If you're looking at only copy number testing without the SNP test, so no enhanced testing, the risk of having an affected child if both members have 2 copies of SMN1 is 1 in 59,000. With copy number testing and the G2713-4 T to G analysis, or the enhanced testing, the risk of having an affected child with both members with 2 copies of SMN1 and negative for G2713-4 T to G is 1 in 627,000. The risk of having an affected child with both members with 2 copies of SMN1 and 1 positive for the G2713-4 T to G variant is 1 in 16,000. The risk of having an affected child with both members positive for the G2713-4 T to G variant is 1 in 4,600. The risk of having an affected child with one member, a known carrier with 1 copy, and the other with 2 copies and positive for the variant is 1 in 136. And to date, we've identified 3 couples with one member identified as a 1-copy carrier, and the other member with 2 copies of SMN1 and positive for the variant. 2 of the 3 prenatals were negative, and the other result is unknown. In general, we have found that the enhanced testing, which includes copy number analysis and parallel genotyping for the G2713-4 T to G variant, adds minimal cost to the test, provides more accurate risk estimates, and has been well received. Thank you for your attention, and we're happy to answer any questions that you may have.
Thank you, Dr. Edelman and Dr. Kornreich. If anyone has any questions, please feel free to use the Q&A function at the bottom of your screen, and I'll give you guys a minute or so to do that. And I also want to let you all know that a recording of today's webinar will be sent to all attendees and to those people who registered who may not have been able to log in for today's talk. Okay, I don't see any questions. So again, a big thank you to Dr. Kornreich and Dr. Edelman. And I want to thank you all for joining today's webinar, and I hope you have a great day.